like in med school where like, oh my God, I have to go log hours somewhere. And it's just painful and like scary. You don't know what's going on. So I think we're just closer to that as residents.
Like, oh my God.
Than like so I think I don't know. And our attendings do a good job of looking out for med students too, but I think we're just closer to like, damn, I know how awkward this feels. So I want this not to be so awkward for you.
Absolutely.
All right. So we are live, everybody. We got some people trickling in, so we're just going to do the regular announcements. So, hey casters, how you doing today? Welcome to today's session. If you're new here after the presentation, we're going to have a Q&A, so make sure to drop any questions you have in the chat. Afterwards, we'll release a quiz/journal entry. This will validate your hours, so make sure you take your time, fill those questions out so you can get the best out of your experience. Also, make sure to sign up for our listserv on our website and join us next week where Dr. Tina Ho is going to have a shadowing session about plastic surgery. That would be Monday, January 18th at 4 p.m. Now to introduce our presenting physician, Dr. Fredericks. He's currently a senior resident in orthopedic surgery at Walter Reed Medical Center. And upon completion of his residency program, Dr. Fredericks will begin a fellowship in spinal surgery with the Rothman Orthopedic Institute at Jefferson University in Philadelphia. We're super excited to hear from him, and whenever you're ready, you can go ahead and start.
All right, guys. Thank you so much for having me. Yeah, so I put together some slides, just kind of about me and residency, but I think the biggest thing for this, hopefully, is some kind of question and answer stuff. I'll answer anything to the best of my ability. No question's too small or too ridiculous. Trust me, it's a unique time, especially if you guys were trying to go into medicine in college and first couple of years of med school or end of college. Like, it's just hard to know what you don't know, and I don't know everything, but I'll certainly try to tell you. So we'll go ahead and start with the slides. So just a little about me. So everyone's calling me Dr. Fredericks. Please call me DJ. I grew up in Anderson, South Carolina. Spent my whole life really in South Carolina until I came to residence here at Walter Reed. Went to Presbyterian College where I majored in chemistry and psychiatry or psychology minor. Went to med school at University of South Carolina, and then I started residency in 2015. So I went straight through from high school to college, med school into residency. So no real gap years. So I don't have too much experience with that, but a lot of my colleagues have done that and have really enjoyed it. So I'm at Walter Reed right now. I'm active duty Army. So I was a reservist during my medical school as a second lieutenant. And then as I finished medical school, I was commissioned as a captain in the Army. And then I've been active duty for the last 5 years and some change. So Walter Reed's a 6-year residency. You do 5 years of clinical work, and then you do a year of research, which is between your third and fourth clinical years. And then a lot, kind of how orthopedic surgery is pointed nowadays is a lot of people are going into subspecialty care, subspecialty regions. And I want to do spine. I really love all orthopedics. We'll kind of talk just a hint on a little bit of the different subspecialties that are in orthopedics, but the trend now is generally people are doing 1 extra year of subspecialty stuff. So I'll be headed up to Philly at Rothman and Jeff next year. So a little bit about orthopedic surgery. I'm not sure exactly how much everyone knows, and we'll figure a little bit more of this out on kind of the question and answer stuff. But at its basis, it's a specialty devoted to diagnosis of musculoskeletal problems, and that includes bones, tendons, ligaments, nerves, and everything in between. So there are probably common orthopedic surgeries that you guys know of, and so like total hip arthroplasty, which is over there on the left, that's a total hip. The acetabular component and the femoral component have been replaced. You guys also probably know of tibia fractures, which are usually treated now with closed reduction, intramedullary nailing. That's what you see there. Then also other common injuries, that's an ACL reconstruction that we've done, and that's kind of the reconstructed ACL bundle here after it's been cleaned out. So there's tons of variety in orthopedics. That's one of the reasons I really loved it, is that I didn't know I wanted to do spine. Certainly going in, I just liked, I think a lot of guys and girls are brought to orthopedics because they liked the finality of there's something broken, I can fix it. And I know this like a common, it's also like a common reason the medicine people make fun of us is like, oh, they're just like dumb ortho bros that just want to fix bones and then not handle their medical problems. And honestly, that's exactly right. But there's orthopedics is a lot more than just fixing bones. There's tons of variety. So these are a lot of this orthopedic subspecialties. So you've got sports, which is a lot of young athletic people, ligament reconstructions. There's some fracture care, obviously, but like ACLs, MCLs, PCLs, shoulder instability, things like that, elbow instability, foot and ankle, which is a little bit of arthroplasty as well as fractures, joint reconstructions, which is what you think of total joint surgeons, hand and upper extremity, which can kind of span the elbow all the way down to the hand to include fractures and ligament problems, shoulder, elbow, spine, trauma, pediatrics, and oncology. So this is a total ankle replacement. They've done a medial malleolar osteotomy to get there, and they fix it on the way out. Everyone's heard of, probably has someone in their family or close to them have total knee arthroplasty, total hip arthroplasty. These are obviously pictures there. Sports and shoulder elbows, a lot of arthroscopy. So a lot of looking through cameras in small portals to work within a joint without opening it completely up. Obviously peds, and then trauma. So this is a big acetabular fracture that got fixed. It needed a total hip arthroplasty on the same side, pubic symphysis plating, SI screws. And a lot of this is, probably you haven't seen enough of it to know exactly what's going on, but just a lot of different variety that you do. And then obviously spine. So I know we want to talk a little about the day in the life of orthopedic resident. I'll take one step back. You guys have probably spoken a lot to surgeons or staff surgeons, attending surgeons. So I'm a resident. I'm in my 6th year. So my day in the life is probably a little bit different, and it will change as a fellow and then change as an attending. But I figured I'd just go through my current day today. So generally, I wake up at 5. That's kind of been the same. You get to sleep a little bit later as you get older. So when I was an intern and a 2, it was before 5. Now I kind of get to run the team, and I don't have to do a lot of the legwork in the morning. I can kind of focus on operative stuff. 5:45, I usually get together with my PGY2, so a 2nd year resident that has rounded or chart checked a lot of our inpatients, for example. And this will be kind of also tailored to the current rotation that I'm on. We talk about the patients and kind of what's going on with our dispo plan is. At 6:30, we have a big morning conference in which all of our attending surgeons and residents attend. And we usually have like a day-by-day conference schedule. So on Monday, we talk about sports cases, preoperative and postoperative cases, interesting cases that happen throughout the week. So everyone can get some learning objectives out of those. On Tuesday, we do spine and pediatrics, Wednesdays, hand, so on. So usually that conference is 6:30 to 7:15, and then we head off to the OR. So usually, in operative days, I'm in the OR from 7:30 to 4 or 5, however long it takes. Today I had clinic, so I was in clinic until right before I drove home for this. But and that's pretty chill. I know Grace has been there with us in clinic, and it's kind of hectic, but you're just running through a lot of patients, trying to figure out signing up patient senior post-op. I try to do a little bit of research each week. It's harder the more clinically active I've been. Like I said, I did a year of research, so I have like a lot of that under my belt. But I try to stay involved in the biomechanics lab, which we have at the spine biomechanics lab, which we have at Walter Reed. And I try to head home at like 5 or 6. So this picture this is just a picture of us the other day of us doing this. This patient is lateral. So head's down here, feet are down here. This is her left side. Her right side is towards the floor. And we're doing percutaneous screws in her L5 and S1. I'm actually sitting down, so it's nice. Sometimes we get to sit down in spine surgery. You generally don't get to, but and then we usually wear loops you see here and headlamps so we can see a little bit better. Go to our next slide here. Oh, that's us in the research lab. So this is Dr. Wagner. This is Tony, our PhD that's in our lab, and a couple of other. This is Mel Helgeson, attending spine surgeon. Dr. Wagner, attending spine surgeon, and we're prepping some samples for some biomechanics studies. This is actually one of our studies. This is big machines called MTS, which allows us to manipulate things in space and determine this force that is generated across different substances and surfaces. We've actually done ACDFs on these specimens. So this is a cervical spine. We've taken out the disc, put in a graft, and then put a small plate on it. We're determining to see how much rotation that there is with different loading, kind of loading strains and stresses. So I'll just put together a couple of cases, just kind of to see a little bit like what is ortho spine. And we do a ton of different cases. So it spans all the way from the occiput, so the back of the cranium, all the way to the sacrum and the pelvis. So me finding 3 different cases that really encapsulate all of them is tough, but I figured we'd go over some things that are common and little things that are uncommon. So I think everyone's heard of scoliosis. It's pretty common, or definitely like a common buzzword. Here you can see this patient is skeletally mature. She doesn't have any, her cartilage has completely fused to the top of her ilium. She was obviously mature enough to get a belly button ring here too, which she didn't take out for these x-rays. We had to take out on the day of the surgery, which was fine and hard. And but you see this large curve that's to the patient's right. So this is an x-ray that is flipped. It is looking like you are looking from her back through her belly. So you see the heart shadow is actually on the wrong side. This isn't normally your heart is to your left, but now the heart is still to her left. It's just, it looks like it's to her right. So this large curve is in her back. So the reasons that we do scoliosis surgery are to, one, like prevent progression. So right now this curve is measuring, I think, at like 50 something degrees. And in adult patients, curves over 50 degrees tend to progress at a 1 degree per year. And that may not sound like a lot, but at about 80 degrees of a curve, you start to really compromise your cardiopulmonary status and your ability to breathe, exhale, get up. You start losing a little bit of your inspiratory power and your longevity and your endurance. So if she's 23 now, she progresses 1 degree per year. When she's 53, she's going to be at 80 degrees, and at 70, she's going to be at 100 degrees. And we really don't want the last 30 years of her life being at a kind of restrained or restricted level. So we commonly will intervene on these patients that have curves greater than 50 degrees or rapid progression. Some things you do for scoliosis when you work them up is you have to determine, so this curve here, you have to determine what we call structural and what is non-structural curves. So structural curves would be like curves that they are not going to bend much. They are stiff. And then the non-structural curves are curves that really are just compensating for the other curves. So if your back looked like this and you didn't have a compensatory proximal thoracic or lumbar curve, your head would just head off this way. And there's no way your body would allow your head to be off to the side. So you will slowly bring your head back over your pelvis and your center of gravity. And that will cause a compensatory other curve. But us determining what's compensatory and what's structural is based off these bending films. So you can see here, she has a large lumbar curve, but when she bends to the side of the curve, it's completely straight. So we know that curve is not structural, it's only compensatory. She's using that curve to stay straight. The same thing with her proximal thoracic curve. Anything that bends out to less than 25 degrees, so you can see here it's 19 degrees, means it's not structural as well. So it means it's strictly compensatory. So all that being said, we're determining what levels we want to fuse in this young lady. So we don't want to fuse the whole spine because that's going to decrease her ability our mobility, our ability to turn sideways, bend forward. Your thoracic spine, you can fuse kind of, or easily without too much loss of motion, because all these ribs are really just acting kind of like a cage for your thoracic spine. You have very little motion through your thoracic spine anyway. You have a little bit of rotation, but you don't have too much flexion and extension because you have your heart and lungs there, and you never would have evolved to flex through your heart and lungs too much, because it just wouldn't be, it's just not compatible with good sustained inspiratory effort and cardiopulmonary function. So there's types of how we categorize these. We base these off a Linke classification. I don't think that's super important, but this is a Linke 1, meaning she just has a main thoracic curve. The rest of them are compensatory and non-structural. And what we did is we ended up fusing her and those levels of that main thoracic curve. So our goal is about a 50% correction. We don't want to completely correct her to make her perfectly straight. That has kind of increased risk of neurologic compromise. You know, you got to think you've got your spinal cord running down through here. So if you bring her all the way back, that's a big move for the cord. So we aim for about 50% or less. So she started about 62 degrees and we're at 20 degrees, which we really like. So these are pedicle screws and rods, obviously, that are put in at all the different levels, and straight rods, and help derotate the spine as well as push it coronally back to more of a straight line. And here's kind of another side of spine, which is cervical spine. You can see here, these are X-rays. This is a lateral X-ray of a kind of skeletally mature individual, and it's hard having not, you don't see these all the time, but it's as us has seen the light, you can see there's a loss of disc space height compared to normal. This patient also has kind of this osteophyte here, which is abnormal. There's osteophytes in the back. This is just looking kind of like an arthritic spine. This patient's presenting though with changes in their grip, dropping things, loss of dexterity, was using no assist device, then used the cane, now using a walker. So they're having this kind of stepwise steady decline in their function, along with pain and numbness, tingling in their hands. Their hands feel like they're, like a stocking glove distribution numbness. So the next thing we do for a patient like this, we can notice obviously on X-ray that there's probably a problem, but we want to go after this a little bit with an MRI. So MRIs are much better at looking at the disc and soft tissues, as well as the cord and the cerebral spinal fluid, than it is the bone. So obviously there was a bony problem there. We can see here, this is cerebellum, brainstem, spinal cord. All this kind of white around is this cerebral spinal fluid. It's normally supposed to look very similar to that. You can see it down here at the bottom too. You see the cord, and there's good fluid around either side of it. There's no significant compression. But as you follow this cord up proximally, you start to lose all that cerebral spinal fluid that encases it. And now the cord's getting really compressed. And especially at this C3, C4, you see this massive disc herniation. So these are the vertebral bodies, and this is the intervertebral disc. And here there's a massive disc herniation that's compressing the cord. The entirety of this gentleman's upper and lower motor, there's an upper extremity and lower extremity motor nerves, besides the ones that have come out at C2 up here. The entirety of his function is passing through this small, tiny space, which is probably 3 millimeters wide. So his cord is compressed completely down. And if he were to fall, hit his head on anything, cause a flexion or extension moment right there, he could easily become a quadriplegic. So what we have to do is we have to decompress the spinal cord. So there's a couple of different ways you can decompress the spinal cord. I think the way you probably think of it first is that you go from the back. So you go to the back, you open up, these are spinous process and lamina, you take that off, you allow the cord to float backwards. But also in spine surgery, we do a lot of neck surgery. So we go from the front. This gentleman, because he had 360-degree compression of his spinal cord, we thought we needed to go to the front and then flip him and then go to the back and do both at the same time. So we first wanted to get this. Our main reason to go to the front is we had to get this disc out. There's really no way to get to the disc from the back unless you really manipulate the spinal cord, and the spinal cord, especially high up, does not take a joke at all. So you cannot grab it and move it even half a disc space to pluck that disc out you're going to cause bruising, intraneural scarring, fibrosis. He's going to be paralyzed. So you got to go from the front. So that's what we did. We went from the front first, went through, you go down to the anterior neck, right behind the esophagus and the trachea. You move that over, have some retractors in. Now you're staring at the very front of the spine. You take some disc knives, rongeurs, little pickers to pull out this disc. And then you go to the back and take down what is called the posterior longitudinal ligament, which runs just on the posterior aspect of the vertebral bodies. And you take that out and then take the disc. You're then looking right at the spinal cord. We did that at each level to decompress all those herniated discs that are pressing on the spinal cord. We put these are integrated fixation devices. So this is a cage that is now between the vertebral bodies that will keep their height up so they won't collapse. Now that we've taken, you've got this really tiny disc that's herniated and disc space level, we go in there and jack it up, and we put this device in there, put one screw up, one screw down. We did that at successive levels. And then we flipped the gentleman on the table and then did a posterior approach to the posterior back of, to the posterior aspect here. We went down. See, this is the spinous process of C2. This is the spinous process of C1. You don't see any more spinous processes at this point because we had gone through and taken off the lamina, which is like the back part of the spine, and the spinous process, which is the part that you can feel when you palpate in the, the back of your neck or your low back. And so then now the cord has been decompressed from the front and it's been decompressed from the back. We put these lateral mass screws in because we've taken out a lot of this. We've introduced a lot of new instability to the back of this patient, and put some pedicle screws in and complete it with a rod. He's now was walking with a walker and now is not walking with an assist device. He had return his function of his hands and is doing really well. And this is just kind of like a more common procedure that I would do. I've showed you, we've done several of those cases I've showed you in the last month or so, but this is something we probably do 2 or 3 times a week, something maybe one of your parents have had or an aunt, uncle. And this is just anterior cervical discectomy infusion. So this is kind of like that previous patient, except this is at one level. So this is a 39-year-old lady who says, I have excruciating right arm pain and a little bit of weakness. My left arm feels fine. My feet feel fine. I'm not having changes in gait or function, but I had this new excruciating pain and weakness. So we get an x-ray, which shows a little bit of disc space collapse. Then we get this MRI. So this is kind of that normal picture I was showing you of here, the spinal cord, cerebral spinal fluid that's around it. She looks a little tight back here, but nothing crazy. It returns to normal down here. But the big area of concern is 3, 4, 5, and 6. So in between 5 and 6, you see this big blob, and that's just a disc that's herniated, or 5-6 disc is herniated out the back and causing significant compression at our cord. You can see it on the axial images. So this is a sagittal cut, and this is an axial cut. So like if you were laying down on your back and we cut you up into a bunch of pieces, and this corresponds to this exact cut here. So you see, this is vertebral body. This is vertebral artery, spinal cord. But then this black blob is this huge disc that has popped out. So it's really compressed. It's making our spinal cord look kind of like a peanut here, which is not, you guys don't know much about spinal cords, but it is not supposed to look like a peanut. This is her back, and this is her front. This is her trachea and esophagus. So when we come down for this approach, can you guys see my cursor? Okay.
Yep.
So the approach for an ACDF is, this is the trachea, this is the esophagus, this is sternocleidomastoid. You have your carotid artery, your external jugular artery. So we come down just right here through this layer, medial to the sternocleidomastoid. I fill your finger for the carotid. Once you're here, you know that if you dive medial, you'll be right on the vertebral artery or vertebral body. If you go lateral, you know that you're out to lateral. So you fill your finger at the carotid. Then you push the carotid lateral, put your finger right down on the vertebral body, pull the esophagus back, and then you put a retractor down, and you're there. It's actually a pretty simple approach. So what we did for this lady is just a single level anterior cervical discectomy infusion. It's a little different implant that we showed you for the The anterior neck was the last gentleman. But went in, took out the disc, went to the back, pluck out the disc that was sitting on the cord. So the cord is kind of right here. Pulled out that disc. This is a allograft bone instead of like a metal cage. They've all been shown to have very similar levels of fusion. So this is just a different surgeon that I work with. He prefers to have me use this allograft strut, and then we put a little plate on the front that has 4 screws, so 2 in C5 and 2 in C6. So she's doing really well postoperatively. Doesn't have no longer any pain or symptoms in her right arm of a previously healthy, like 39-year-old lady. So I guess so. Those are the cases. I'll just save this for really any questions. I did have like a little bit about me. So I am married. This is me when I had like some amount of hair, or I was convincing myself that I had hair. Lots of product. Sun's hit me right, so you could be convinced that I had some hair. This was 4 years ago, and then we don't have any kids. I got a little yellow lab. He's sitting right here beside me right now, and his name's Woody. But life's pretty good. It gets better as you go on throughout residency, and I hope it gets a little better as an attending. But it continues to be up. What I do for fun is I play. I work a lot, but the things I do for fun, I play golf. So this is me and my dad in St. Andrews on 18. And this is us also in Scotland, and these are 3 or more of my residency classmates. These are all Chiefs. This is when we won the 69th annual Walter Reed golf outing last year. So that kind of concludes my presentation. However you guys want to do it from here. Any questions? I'm free. I'm all yours.
All right, sounds good. We got a bunch of questions from the audience. And a lot of them are curious about your career in military medicine specifically. We have a couple questions about that. The first is, how did you know that you wanted to be part of a military-based medical system, and what kind of attracted you towards that?
So I think so. My dad was in the Army, and I never really knew that so my dad was in the Army. I thought I wanted to be in the Army when I was a little kid. But then I had like when I decided I wanted to be a doctor, I was like 7 years old. I was in this like terrible car accident, was in the hospital for a couple of weeks, had like multiple abdominal surgeries, blah, blah, blah. But was in the hospital on the peds floor in Greenville for a while. I was like N64 and good food, and the nurses were awesome. And I like left the hospital being like, I just want to be a doctor. So then I just like resigned myself seemingly to like, I didn't think that those two things could exist. And then when I was in college, one of my buddies was like 3 years ahead of me, or senior when I was a freshman. He accepted like the HPSP scholarship, so the healthcare professional scholarship, to go to civilian med school, but then join the Army afterwards. And I didn't know anything about that till then. So my eyes were like open at that point. I also like wasn't real. I was not. I was never gonna be cool with like being $400,000 in debt. That's just like how I thought that. Now I went to med school with a lot of people that are very successful and did just that, and it is not the end of the world. Like they are doing just fine. So I don't want to dissuade anyone like, oh, military is the only way to go. But that was like another reason. I was like, damn, I don't know. Like my parents aren't helping me out pretty much. So this is going to be up to me, and that sounds scary. So then I just started talking to the Army and Navy recruiters about it and went on a couple of visits, and I thought it was awesome. So it has been awesome. There are problems with any healthcare system, I think, civilian or military, and there's some unique problems when you're in the military, but there are also some really unique stuff you get to take care of that I don't think you get my civilian friends to get to take care of. So that's kind of my journey into military medicine.
And
I'm turn on the light. Sorry.
Perfectly into our next question, which was asking, what would you say is the best advantage, or even a couple, of practicing medicine through the military, and would you recommend it?
Yeah, I would recommend it. Advantage.
Or just differences, like things that you notice that are different
so
you might enjoy.
so
Yeah.
I think the thing that is most unique is obviously you're taking care of war wounded individuals like on a weekly basis. Now, it isn't awesome that people step on bombs or IEDs or get shot with high velocity rifles, but if they are going to in defense of the country, it's awesome to take care of them. Now, 90% of my day is not taking care of guys that are coming over from Iraq, but there is at least once a week someone's flying back from Iraq or Afghanistan that has been severely injured, and we get to take care of most of due to the type of war that's been fought over there. It's mostly dismounted. Originally it was mounted, but then now it's been dismounted blasts, and like all those are extremity injuries pretty much. So orthopedics has been like called to the forefront to take care of our guys and gals that come back. And to me, that's awesome. Now you get to supplement a lot of that war injury stuff with a lot of subspecialty stuff within the military system. And then also we do a lot of outside rotations at other civilian trauma centers and civilian joint centers and spine centers. So I think you get a tremendous mix of a lot of different stuff, and you get to be a part of, taking care of like American heroes. And I think you get numb to that early and kind of jaded because you're like, shit, this is a lot of work. And it waxes and wanes based on like operational type things. Like, in 2011 and 2007, it was crazy busy at Walter Reed. And all it was that type of those type of injuries. And now it waxes and wanes based off certain things. And we certainly don't want any of our guys and gals getting injured, but it is an honor to be able to take care of them.
That's really cool. And I think the patients, at least that I got to meet, were so cool. And even hearing some of the stories from them about the patients, how much interaction in terms of picking treatment options and recovery do you get to have with those patients?
You get more say the older you get. So generally, you're an intern in a two, you're not indicating these patients, so they're not coming to you. They're coming to another attending, and the attending is scheduling them for surgery, and then you're operating with that attending on whatever said day. So you're not dictating their care. Now you're taking part in their surgical care and certainly their post-operative care before they're discharged, and their post-op care as an outpatient. You're very involved in that, especially as if they're admitted, you're taking care of these patients on the floor. As you get older, you start to become more of the decision-making process as you kind of morph into like a youngling to more of a junior peer for the older attendings. And then you can have a lot of say in learning indications and how is as, if not more important in your surgical training than learning the steps of the surgery and how to move your hands and when to do that and when to close this and when to put a graft there. So you get to be part of that. But as a resident, it's not your name that's on the check. So generally the attending is going to make the final call. You're going to be part of that decision-making process. Either way, you're going to learn.
Cool. All right. Shifting gears a little, we have a couple questions from the audience about research. So what does your research focus on? And is it something that you think you'll continue to pursue like in the future of your career?
So my research is mostly focused on spine. Early on, so taking a step back, I wasn't really active in research as a medical student. There wasn't a good infrastructure that I've tapped into, at least. Maybe there was. And I was just like selfish about grades and really just didn't want to do research. I didn't have a lot of experience writing. And that's kind of what your role is as a med student, is to write and do some data mining. So I didn't really I must have not just matched up with the right residents or whatever it was. I am not probably, I am glad that we had our research here because it really focused me to do research. I first started when I was like a 2 doing some data mining for some patellar tendon outcome studies, and I had some seniors that reached down to me that I guess saw that I was, good in the OR or whatever as a junior resident, and I might be involved in some research. So did like a couple projects as a 2, did a couple presentations. Nothing got published until I was like in my 3rd year of residency, but kind of did a little bit. You're just really clinically busy. So 1 or 2 projects a year is doing a great job during your clinical years. As a research resident, or in that kind of year interim where I wasn't operating as much, I really focused my efforts to spine, because I knew for me to get a fellowship, for me to be competitive against a lot of guys and girls across the country, that's another, you can be the best in the OR and you can have the most glowing letters of recommendation, but like everyone's going to have those great letters of recommendation. So research kind of helps you set you apart. And so I was able to publish maybe 8 or 9 things from our research year, mostly on spine, a couple sports things about meniscus and this, that, and other. But now I probably have about 15 or 16 publications, with another 5 or 6 being written right now. So my goal, I'm going to be probably an academic spine surgeon, hopefully, in the future. So kind of curating my CV to that is a little bit of a goal. Now, my research focus within spine is kind of across the board. I was just like grabbing anything I could get a hold of, helping whatever I could, just to kind of increase my numbers at first, I feel like. But I think biomechanics is awesome. To me, it makes a lot of sense. It's very applicable. And doing cadaveric studies and testing them, I think is just really cool and just gives a lot of feedback. So that's what I think now, but we'll see how that changes.
Yeah, you were showing that picture of the machine that was testing kind of like force and flexibility with the ACDF procedure. How do you kind of like integrate that when you're talking to a patient, like talking to them about flexibility? Like, how do you take that research and translate it into like your everyday treating patients? Well,
for example, that project was based off of, if you guys can look at this picture here. So this is pretty much what we did to that segment of spine that we were working with. So sometimes these ACDFs, or these vertebral bodies, have these large osteophytes that come out here. And a lot of times we'll shave them down. We'll like shave them down when we put the plate on, so the plate sits nice and snug. But that osteophyte is pretty good bone. It's very hard bone. And now you're putting screws through good hard bone. It really feels like you have good fixation. So we're trying to see if there was any difference really. If you shave down the bone versus not shaving down the bone, would that change the construct stiffness? With the goal being, the more stiffer the construct, the more likely it is to fuse across these 2 vertebral bodies, and the better it is. It's very, it's hard. We're kind of making a leap of faith there. So we found that there really was no difference. It wasn't like stronger or not stronger if you took down the bone or not. So that makes a difference. Getting back to your question, in my day-to-day, not necessarily when I talk to patients, but when I actually do this surgery, I don't feel so bad about taking down that osteophyte. If we had done that project and it'd be like, yeah, if you take down the osteophyte, it's like 4 times weaker. Like, well, shit, we shouldn't do that. So it makes a difference in like how, that project in particular, that's the clinical question, is like, should we be doing this or should we not? I've also done like bigger projects where, not bigger project, like non-biomechanical projects, where we reviewed every micro discectomy. So every little disc herniation surgery we had done in the military. And then we reviewed how many of those needed a second operation for a repeat discectomy. And we found it to be 4,000 patients that had a microdiscectomy, 400 needed a reoperation. So it's like, all right, 10% of patients that have this surgery may need another surgery. And I tell patients that all the time. I told a patient that today that we signed up for a microdiscectomy. They're like, well, what's the chances I need another surgery? I'm like, well, I would have normally said 5%, but we just reviewed everyone in the military and it says 10%. Now, I'm not saying it's somewhere in there, but it's not 0% and it's not 1%. There's somewhere between 5 and 10%. You're going to need another operation for this, even if we do the first one perfectly. So those are different ways, either surgically or when talking to patients, like we can use what we find in research.
We have a couple questions about the cases that you presented. that actually go along with the discectomy that you're talking about. This is a question that I had when I was shadowing. When you remove the disc, what are you replacing in that space, or are you replacing that space at all? Like, what do you do after you take out the disc? Yeah.
So in terms of the cervical spine or the lumbar spine?
Either.
Okay. So when we talk about a micro discectomy, so people that have lumbar disc herniations and you hear like micro discectomy or nerve root decompression, usually a part of the disc is pooched out, and it's not pressing on the spinal cord at that time, because in your lumbar spine, the cord is ended at L1. It's just nerve roots. So there's a disc that's pooched out posteriorly and pressing on a nerve root. That's the thing that's causing the majority of the pain. So we will go posteriorly to burr down a little bit of bone, take out the ligamentum flavum, which is this long ligament that runs in the back of the spine, move the nerve root and grab and pluck out the disc. We generally don't put anything back there. So you're not taking out the entire disc. You're just taking out a very small portion of the disc, and the portion of the disc that has declared itself unhealthy because it's no longer within the annulus or the normal circle of the disc. So we don't put anything else back. We make sure there's not any loose fragments. We don't put anything else there for that surgery. Now, there are some lumbar surgeries where you go and you remove the entirety of the disc and you put interbody cages or interbody devices. Now, those can range from allograft dead person bone to titanium to PEEK, which is a type of kind of specialized kind of inert plastic material. So it depends on the long story short, it depends on the type of surgery. Now, in the cervical case, you can see here, we take out the entirety of the disc and all the cartilage that's between the vertebral bodies. So here we're putting this is a piece of femur from a dead person that has been milled to this specific kind of trapezoidal shape. So it will fit between these two. This holds the vertebral bodies from collapsing down on one another. This will eventually, the kind of bone will grow from this vertebra through this dead bone into this vertebra, and this will all be one solid bone in about 3 to 4 months. You can also put titanium or PEEK cages in here, but generally you're putting, if you're taking out the entirety of this, you're putting in an interbody device made from usually one of those three materials.
Cool, thank you. We have a couple more questions. People seem to be really interested in the military service part of it. What does your service look like after your fellowship, and as you get older, what does your obligation look like?
Yeah, so in the military, in GME, you owe, usually it's kind of different if you get over 3-year residency or under a 3-year residency. So for example, I think if you're a family doctor and you do a 3-year residency, you owe the military 3 years after that residency. For orthopedics, you owe, if you do a 5-year residency, you owe 4. And if you do a 6-year residency, you owe 5. So I right now owe the military 5 years after my residency. Now to do a fellowship, you owe more time. So it's either 1 for 1. So 1 year fellowship incurs 1 year of payback, or 1 for 2, which is the way my fellowship is. So I owe 2 more years on top of my 5. So I owe 7 years after I finish my fellowship. So I finished my fellowship in 2022. The first time I can get out of the military is 2029. So that's kind of how it works now. Surgery is you end up acquiring more time than you owe in surgery because it takes longer to train you. Their thought is, we're going to train you this long. I want you to be a spine surgeon in the military this long, which to me, in terms of was it worth it? It was like a no-brainer. Like, of course, like being a spine surgeon in the military is pretty good and cool. You're paid a little bit less than you are in the civilian world, but it's like a lot of great experience. And so I jumped at the idea. I didn't worry about the payback, and so did like all my classmates when it comes to fellowship. So my classmates are doing, one of us is doing hand surgery, 2 of us are doing trauma, and another one is doing joints or adult reconstruction, and I'm doing spine.
That's awesome. I'm so excited for you guys. Do you plan on deploying? Is that something in your deck of cards for the next couple of years?
Well, it probably doesn't really matter if I plan on deploying, but the Army damn sure plans on me deploying. So usually your guys are deployed within the first 18 months of their end of their training. So when I finish fellowship, I'll probably deploy one time within the first year and a half. And then right now it's every 3.5 years you'll deploy. So it's usually 4.5 to 6 months you're gone or not clinically active. You're usually just in theater for maybe 4 months or a little less. So I will probably deploy at least twice while in the military. Yeah.
Good to know. Cool. We also have a couple questions about general med school stuff. Some people want to know, did you have any reasoning for not taking a gap year, or do you wish you had?
I only wish I had, because I had a lot of friends that after I met them in med school, they're like, oh yeah, I just was a ski instructor in Telluride. It was awesome. I'm like, dude, that sounds incredible. I don't know why I didn't do that. It's probably because I was poor and I couldn't do that. I didn't have the flexibility to do it. I'd never thought about it until I met my med school friends that had done it. And I was, I wasn't interviewing at Harvard and Yale for med school. I got 3 or 4 interviews, and as soon as someone said you can come, I was like, I'm going. I don't want to try it, test it out. So I don't think there's any specific disadvantage for going straight through. There's some people that use that gap year to do more research and do more clinical shadowing, and I guess that looks good. I guess I was mostly just jealous that I couldn't work at a golf course for a year, which I would have done.
Yeah, it seems like you talked about how you like golfing and that kind of thing. How do you kind of keep that work-life balance? Do you consider your work-life balance good?
Yeah. So work-life balance, so another step back, orthopedics is really competitive to get into, and then it's really hard the first 2 years. Like a lot of surgical subspecialties. Your second year is probably one of the toughest years. That in neurosurgical is neurosurgery. Second year is probably one of the toughest years in all of medicine. There is no work-life balance during that year. It's just you're just trying to make it by, because it's going to get better, and what you're doing is fun, and it is fun. It's just a lot of hours. So I didn't play a lot of golf for a lot of years, but then and just substitute golf with whatever the hell it is that you guys like to do. I didn't do a lot of stuff I like to do the first couple of years, and I started to get to do more of stuff I like to do my 3rd, 4th, 5th year. And that's just kind of the price you pay, and that's the club you sign up for. I think you got to make time for your family. I haven't had obviously any kids. I have a wife, but a lot of my classmates have kids, and it's just kind of about what your priorities are. There's only a certain amount of hours in the day, so you've kind of just got to figure out how to do that. Everyone, not everyone can do it, but I do think it just takes a little bit of effort, and you can figure it out.
Yeah, you said that you guys squeeze in 4 procedures a day. How long are those procedures usually?
So it depends. So that scoliosis case, for example, that's the only case that day, because it takes about 6 hours, or from start to finish. Surgery itself is probably only 4 hours, but positioning, draping, getting her off the patient table to the PACU, make sure they're stable. But if we do micro disc, like this case right here, probably skin to skin is about 50 minutes. A micro disc is probably similar, maybe about an hour, 50 minutes, depending. They all can be very different. But yeah, it's generally we do two to three cases in spine, depending on how big they are, and sometimes we have multiple rooms. The joint service usually does 3 total joints in a day, but we are also an academic institution, so every case is like teaching a resident how to do something. So generally it's much slower than if you're at a civilian place, or maybe Emphasis is not placed on resident learning as much as it is case volume, because that's how you get paid. That's another thing that's great about being in a military health system, is that all this money is from the government. It's already been budgeted. We do not need to go faster to make more money. We do not need to do more cases to make more money. So we can spend a little more time. It's a great environment to learn. But yeah, to answer your specific question about how long did it take, it kind of just depends on the case.
Yeah, you mentioned the scoliosis case being a really long one, and even for some of the shorter ones, I remember you guys doing neuromonitoring to help prevent nerve damage to the extremities from those risky surgeries around the spine. I think everyone else would kind of like to hear about it because it's cool. Do you want to talk about neuromonitoring real quick?
Sure. So neuromonitoring is just a way to see how, it's just kind of a snapshot of the nerves that's going on in the body. So there's kind of two different broad types. So somatosensory evoked potentials, or SSEPs, where you are stimulating, or you're seeing if you're picking up any sensory problems in the peripherally. And then there's motor evoked potentials, which are electrodes that are placed in the top of the head over the motor cortex. And then there's electrodes that are distal. So you can, as you're doing spine surgery and manipulating nerve roots, as you irritate a nerve root, the signal fires from the nerve distally, and the electrodes can pick up that signal to see, like, oh, you're hitting the C5 nerve root, or you're hitting the C6 nerve root, or the L4 or L5 nerve root. So like we get feedback to like, hey, we're close to this thing, because some of it's not necessarily blind, but there's soft tissue that's involved, and there's pedicle screws that are involved. We can also stimulate the pedicle screws that we put in to see how close they are to those certain nerves. So you send electrical current through the pedicle screw. You can think if there's a nerve and there's a pedicle screw, and I send electrical current through this pedicle screw, they can look at the L4 nerve distally in the foot and be like, the L4 nerve is not picking up any signal. It's like, okay, well then the pedicle screw is probably not very close. But if the pedicle screw is close or touching it, if I send an electrical signal down that pedicle screw, which is titanium, they can be like, yeah, I'm getting signal on the L4 nerve root. So like, shit, it must be pretty close, or we need to change this direction. Motor evoked potentials are when you stimulate from up top and you see how it travels down to the body. So you fire over the motor cortex, you get flexion or activation of all it goes from the upper brain to the upper motor neurons down to the motor neurons down to the distal sensory nodes, or leads. And it can tell you get baselines. So you're like, all right, that's how fast it takes this nerve to conduct. And then while you're doing the case, you can keep running motors, is what we call it, and you can see if there's any interval change. So if there's been interval change, then like, hey, one of the last steps we've done has changed how long it takes for this electrical current from get the head to the foot. So we need to undo that until it's back to normal. So long story short, it's giving us a snapshot in how the nerves are going from the sensory to the central nervous system, and going from the central nervous system to the sensory via SSEPs and transcranial motor evoked potentials. So we use both of those in tandem.
That's really cool. Thank you. We got a couple questions about, different technology you use on a day-to-day basis. So thought that'd be cool to ask about.
Yeah.
We're running out of time a little bit here. So our last question that we usually finish off with is, what advice would you give to someone in our shoes right now if you were sitting in our shoes right now? I don't know if that made sense.
Okay. So who's on this actual, I know some of this is going on YouTube, but where are you guys all in your training in terms of school? Can we just go down the line?
We're
all
juniors. And
all
we're
juniors
all,
in college.
Either applying this cycle or next. Yeah.
Okay. What advice? So, I think the biggest thing, if you want to go into medicine, the first thing you got to do is you just got to get into freaking med school. So it's been a long time since I took the MCAT. but the biggest thing is just, you just got to make your CV, you just got to strengthen your CV and the best that you can to get into school. I think let's take you guys getting into med school as a given. In medicine, you got to do, like, I'm a big believer that, like, people kind of are who they are, not like a predeterminism type thing, but like the things that you like to do now are the things that you're probably going to like to do for a long time. And the things that like make you happy now are the things that are probably going to make you happy for a long time. So like I like to fix stuff. I like to do stuff that had like instant gratification. I like things like that when I was growing up. I like to play sports. I like to be a part of a team. I like to have camaraderie with with the people that are around. And I'm not saying that is ortho and you should do ortho, but you got to find a lot of it is what you love, like the medicine specialty that you love, but you're all there to like help people. So helping people takes you a long way, but then also like combine that with things that you like to do. So like if you like doing procedures, then I would start focusing on that when I was in med school. It's like, if you like helping kids get through hard times, then I would start focusing on that. If you like talking to people, and that's, your interpersonal social intelligence is what you're really drawn to, then I would focus on that. I think kind of picking your tribe of, looking at while you're in med school, looking at the people you're rotating with, how they interact with one another. Are they happy? And I know that it'll probably be, really kind of be based on the place you're rotating at. It could just be a specific hospital. And so not reading too far into that is important, but just like trying to take a broader picture of like, all right, I've always wanted to be a cardiothoracic surgeon because I think cardiothoracic surgery is cool and it looks cool in the movies and this, that, and other. It's like, well, there's a lot more to being a cardiothoracic surgeon than just like being the freaking hero in on Grey's Anatomy. So I think just like as soon as you're like honest with yourself, like what I like to do, that's going to really help you not be unhappy with like your residency choice and your specialty or subspecialty that you decide to go into. That was pretty rambling. I got it, but I really just should have prepared more for that question.
No, that was an awesome answer. And I think it's helpful to hear about, I think we think about sometimes we get insecure because we spend so much time preparing to go to med school. And then we think to ourselves, what if we don't even like it? Well, if you like it now, probably like it later. That's awesome.
Yeah.
Thank you.
Spoiler alert, you might not like med school the first couple years, but that's fine. So don't worry about that. Don't worry about not liking memorizing biochemistry stuff. That is not what medicine is, but it's just like the game you kind of have to play to get to your third and fourth years, which are much better, and you start to be a part of taking care of patients.
Definitely. Thank you so much. This was awesome. Thanks for coming on here.
Of course. Anytime. You guys, please get my contact information from Grace. Any questions, concerns, comments, you guys want to talk to me offline, email, whatever, I'm always available, and I have tons of friends that also love to help with any type of mentoring, things like that. So please just let us know.
Absolutely.
Thank you again, Dr. Fredericks. We really appreciate it. To everybody watching, we're going to send out the quiz right now. Make sure to fill that out to the best of your ability and really take time answering those questions and reflect on what he's discussed today. Again, make sure to sign up for our listserv on our website and to join us next week, Monday, with Dr. Tina Ho, Plastic Surgery. And make sure to like and subscribe too as well.